Hello, everybody. Thank you for joining us today. Welcome to Module 2 in the American Hospital Association's conversation on social determinants of health, moving upstream using quality improvement. My name is Dr. Rishi Manchanda, and I am the president of HealthBegins, and I'm joined today by my colleague Sara Bader, who is a senior manager for upstream quality improvement at HealthBegins. We're going to jump in today by going through a few learning objectives. First, today we want to make sure that you're able to leave this module by being able to describe upstream quality improvement and related tools that you'll learn about today. We also want to make sure that by the end of this webinar, you're able to identify opportunities to use upstream quality improvement to advance your work on social determinants of health. And lastly, we want to really spend a moment helping all physicians and other health professionals who are listening into this module to understand their role in championing upstream quality improvement campaigns as part of an overall goal to improve the health of patients and the communities we serve. So with that in mind, let me spend a moment just giving some background on what we mean by upstream medicine. Upstream medicine is a term that we use at HealthBegins and with a growing number of our partners, including at the American Hospital Association, to describe the intersection of three different fields. We know that there is a growing emerging body of research and work in the social determinants of health, represented on the bottom right of your screen. We certainly know that there's been a lot of work on population medicine, which is generally the purview of healthcare systems, including hospitals. And it's been around for a long time. This is the work of community-oriented primary care, of social medicine, which has been a long tradition in Western medicine, and of preventative medicine. And we also know that there is increasing, over the last several decades, increasing emphasis on health systems improvement. That includes everything from improving the management of our performance as institutions, on care teams, using tools and methodologies of quality improvement, as well as broader initiatives around practice transformation and payment reform. At the intersection of these three areas of work, especially when health systems improvement and population medicine meet the social determinants of health, that intersection point is what we describe as upstream medicine. It's the modern version of community-oriented primary care and social medicine. It's the clinical manifestation of the social determinants of health. It's the application of health systems improvement to address social determinants. In other words, this is where all of these three streams come together to form what we consider to be upstream medicine. So we know why social determinants matter, but you know that upstream medicine is more relevant than ever. We know that the quadruple aim is very much related to social determinants of health. For example, in a prior conversation in this series, Dr. Jay Bott and myself had a conversation about why the social determinants of health matter. We mentioned that the social determinants of health are related not only to patient experience and the quality of care that we provide our patients. We know that social determinants of health are linked to, of course, population health outcomes and the disparities that sometimes exist that we need to address. We know that social determinants of health are related to the emerging interest in controlling and, if not decreasing, total cost of care. We also know, of course, that social determinants of health have direct relevance to the fourth aim, the quadruple aim, which is joy at work, the professional joy and resilience of physicians and other health professionals. So we know that these things are related, and we've talked about that in this series in a previous module. We want to focus on this module into not so much the why anymore, but really focus on the how. And that's what the next segment's going to be about. I'm proud to pass the baton over to my colleague, Sara Bader. Sara?
Great, thanks, Rishi. I'm excited today to be speaking with you about upstream quality improvement. However, before we go too deep on specific methodologies or approaches, I want to spend a minute just thinking about quality improvement in general. And I think that most of us know it and use it here to improve care at the bedside. And hospitals across the country are running improvement projects on all sorts of things, from reducing infections or other hospital-acquired conditions, to improving wait times in the ED, or using a culture of continuous improvement to establish more reliable systems. And all of this has really been astonishingly successful. As we know, however, a person's health is not defined only by what happens immediately preceding or within the four walls of the hospital. So as you think about how to improve care and the health of the individuals you serve, how can we use those same improvement methodologies to move further upstream, perhaps up here? How can we run an improvement project the same way that we would bringing together different teams from within the hospital with different teams from within the community to address social determinants of health? This idea, using quality improvement to advance and accelerate upstream work, is what we call upstream quality improvement. And it exists at the intersection of the use of improvement tools and methodologies that hospitals have been using so successfully for so long, with the need to look at new upstream care pathways given the social factors that impact health. And what we've seen is that while that question of how do we move upstream might seem overwhelming or insurmountable, that actually by using quality improvement methods and tools that you're already using, you already have the answer as to how, and you already know how to do it. By thinking about those same tools and resources in a sort of different way, you can make those same large gains happen upstream.
However, we don't suggest that moving upstream is as easy as running just one or two improvement projects. And actually, we don't think that project is a big enough term to cover the sort of change that upstream improvement work encompasses. Instead, we use the term upstream quality improvement campaigns. And I want to spend a minute talking about the distinction between a project and a campaign. We know that upstream work is transformative, and therefore there is a level of commitment, there is a level of partnership, there is a level of innovation that occurs within an upstream QI campaign that goes above a traditional improvement project. For example, a project might involve one organization, whereas a campaign may be guided by staff from an organization, but also include members of the community who are directly involved in developing and implementing it, and may also help to evaluate it too. A project will usually focus on a service or an individual behavior change, whereas a campaign might focus on changes in policies or institutional practices or social norms. And because of that, a project is usually non-controversial or only minimally controversial, whereas a campaign, because we're getting into changing social norms, is likely to encounter opposition and potentially in a public way when it challenges the status quo in communities or in the institutions. In a project, a small or finite group of people are involved in that project kind of from the start to the finish, whereas a campaign seeks to kind of build and engage an ever-expanding number of people who will participate in this campaign and future campaigns for social determinants and equity. A project might contain predetermined and specific goals, objectives, and results, whereas a campaign also has those specific goals, but it also has a flexible strategy so that it can respond to incidents as they occur in order to further the campaign's overall goals. A project must be accountable to the funder and the organization's board, whereas a campaign might be accountable to more than one organization and also to members of the community. And a project may encourage dependence of people in the community on one service organization, whereas a campaign encourages the development of new leaders, skills, and the empowerment of members of the community within this work. So as you can see, a campaign just kind of has a little bit more oomph behind it. It's a little bit bigger in terms of scale, in terms of number of organizations and partners and pieces that are participating and are required to launch a successful campaign. And it's really not to say that a project is not a place to start. You might very well start with a project as part of your campaign. The campaign might be made up of multiple projects, but we like to differentiate between the two and really kind of use that upstream QI campaign as something to really get behind to transform the work and the care for your patients.
So let's look quickly at an example of an upstream QI campaign. This is the work of an FQHC within a large public hospital system. And they chose to launch a campaign around food insecurity and specifically focused on using the power of individuals with lived experience to train their physicians on both why addressing food insecurity and screening for it is important, as well as the resources that were available to these providers and these patients. What they saw was that over a 3-month period, so really a very short period of time, their food insecurity rates went up from virtually 0 to 94%, meaning that they screened almost 4,000 people, over 800 of whom screened positive. And those were 800 people whose social needs would not have been identified by the existing system. And they ended up writing over 1,500 prescriptions to a food pharmacy and verifying that 600 of those were filled. And I think also important to note here is, and that kind of makes that connection back to the quadruple aim, is that their providers reported a 300% increase in their confidence to address food insecurity. So they were now able to help their patients in a way that they couldn't previously because of this new upstream care pathway that had been opened up through their upstream QI campaign. So let's shift now and start to talk about the methodology around how to operationalize this upstream quality improvement work. And let's frame it with a story. Rishi, can you introduce us to Mrs. M?
Absolutely. Thanks, Sarah. Let's bring the concept of upstream quality improvement to life by meeting Mrs. M. Mrs. M is a 46-year-old mother of two. She also cares for her frail elderly mother who lives with her. She holds down a job and she has basic health insurance to that job. She also happens to have type 2 diabetes that unfortunately is poorly controlled. Her last hemoglobin A1C was 8.1. At the end of the last month, Mrs. M was at work and her coworkers noticed that she looked really ill, was about to pass out. She nearly fainted at work. And so her coworkers called the paramedics. The paramedics escorted her to a hospital such as yours. And the ensuing workup led to an admission, and the admission and the subsequent series of tests that she had run led to a diagnosis of hypoglycemia, low blood sugar. In many cases, we would be right to look at biological or even behavioral causes that could have led to this hypoglycemic admission. In Mrs. M's case, the reason for her admission was actually linked to food insecurity, the social determinant of health, and something that many systems are still currently not equipped to assess, if not address. It's a social need that more and more of us in healthcare, as physicians, as hospital staff, are realizing is an important social determinant to look at. And we're realizing this because of evidence. The evidence that's coming out demonstrates that lower income diabetic adults, like Mrs. M, have up to a 27% higher rate of hospital admissions at the end of the month due to food insecurity compared with higher income diabetics. In other words, at the end of the month, when the food budget runs out for patients like Mrs. M, who often have other competing priorities and needs, such as paying for rent, paying for the care for her children and her mother, taking care of other expenses, oftentimes at the end of the month, the budget runs out for food. And after feeding her loved ones, her children and her mother, and after paying for the rent and other utilities, Mrs. M actually ends up skipping her own meals. At the same time, she takes her blood sugar lowering medication and therefore has more and more episodes, including this severe episode where she was so symptomatic she ended up getting hospitalized for glycemia related to taking her medications on an empty stomach in a food insecure household. This is a far too common story in America, and it's a story that perhaps many of you are familiar with. The question, of course, is now how can we take an upstream quality improvement approach and take a stepwise approach to be able to build our capacity as physicians, as leaders, and as clinicians in general in our hospitals to be able to go upstream. The stepwise approach that we recommend at HealthBegins is really 5 steps. It starts first by really getting specific and talking about our priority populations. Who are we talking about when we talk about social determinants of health, when we talk about issues like food insecurity or housing insecurity, transportation barriers, social isolation? It oftentimes is helpful to actually hone in on the specific patient population that is a priority for us in our institutions. So for example, in the example I provided with Mrs. M, our priority population might be adult diabetics. The other step after identifying a priority population is then to identify a high priority social determinant of health that is related to the health needs of that population. In this case, as we've described, food insecurity is a major social determinant of health for this population of adult diabetics like Mrs. M. So we've gone pretty quickly through identifying those first 2 steps. It's important to note that that this is really an intentional stepwise process, and that when you're considering this and doing this with your teams, with your colleagues, for your patients, it's really important to actually spend time and deliberate on who the priority population should be and who and which social determinants of health are high priority. But for our example today, we're going to now move on to step 3, presupposing that adult diabetics with food insecurity are our priority population. The key challenge for a lot of hospitals and a lot of community-based stakeholders, like those who run food banks and other food resources, when it comes to taking care of adult diabetics with food insecurity, is how to get started, how to map out the existing resources that are already there, and then more importantly, to identify the opportunities for real change. And that's where the next step comes in. What we've learned at HealthBegins is that it's important to have each stakeholder describe their priorities based on levels of prevention. And in this case, it's primary prevention, secondary prevention, and tertiary prevention. For many physicians, this is something that's quite familiar. Most of the work we do in America's hospitals is in fact tertiary prevention work. In other words, we administer interventions to arrest the progress of an established disease and to hopefully control its negative consequences. Some of us are also engaged in secondary prevention efforts to try to intervene to slow or stop the progression of a disease, to catch it early if possible through adequate screenings. For the most part, in clinical medicine, we are engaged in tertiary prevention and secondary prevention. With occasion, depending on the nature of your work, you may also be involved in some efforts at primary prevention. It's notable that many of our stakeholder partners in the community sometimes don't think through the lens of primary, secondary, tertiary prevention at the outset. And if they do, they might view themselves as folks who are involved at different levels, as people who are working at primary prevention by providing food to those who need it most, or looking at secondary prevention. So it's important to use this lens of prevention to be able to understand what our priorities are and the priorities of those in the community. And then to pivot to not just look at levels of prevention, but later on look at levels of intervention. So another way to understand priorities is not just by level of prevention, but by level of intervention. So we know in the healthcare setting that most of our work is targeted towards individual beneficiaries, in other words, patients. So too are the interventions of many of our social service organizations in the community who focus on individual clients. Then there are organizations that actually direct their interventions towards other organizations. They help other organizations manage their employees, manage their contracts with vendors, engage with other partners, improve relationships with or recruit investors. There's a whole group of organizations in the community that oftentimes are looking at how to impact and shape the behavior of entire organizations and not just individuals. And then there are those in the public health community, especially, and policymakers writ large, who often look at levels of intervention at the whole community level. They're looking at zip codes, if not cities or whole states, and thinking about how they can direct interventions to the entire broad swath of those populations. This level of interventions is just as valid and important sometimes to make sure that we understand the priorities of stakeholders beyond just levels of prevention. So the question is, of course, what does this all mean? How do we roll this up in a way that becomes clinically useful for us as we plan out our approach upstream? And the next slide really represents the mashup of how these things come together. We call this the Upstream Strategy Compass. And what the Strategy Compass really does is to bring together levels of prevention and levels of intervention into literally the same page, so that when we as physicians and when we as stakeholders in the hospital start thinking about the available opportunities and also the barriers that exist for our priority population of diabetics. And when we think about the health-related social needs, specifically in this case, food insecurity for those diabetics, we can start thinking about what already exists in the community in a way that oftentimes it's outside the walls of just our hospitals. So in this case, the first step in using the Upstream Strategy Compass is to map existing barriers and to map them together in this 3x3, the Upstream Strategy Compass. It's important to not just map barriers, but then on the next slide, to be able to identify potential solutions. Solutions to both improve the social determinant of health, in this case food insecurity, but also to improve care for patients who suffer from food insecurity, in this case our priority population of adult diabetics. So for example, you can see how some of the solutions can be represented again here in this 3x3, this Upstream Strategy Compass, in a way that again starts to help us understand the different opportunities that exist, the existing solutions that may already be there in the community. So the question at this point is, as you're reviewing this and you think about your hospital and the community that you serve, what are the existing barriers and more importantly, the potential solutions that may already exist in your hospital and in your community to be able to improve care for patients like Mrs. M with diabetes who happen to also have food insecurity? This would be a process that you could go through to create your Upstream Strategy Compass for that specific priority population. And in doing that, in going through the first step of mapping out the barriers and then the opportunities, you can then go on to the most important step here as part of any successful change management campaign, any successful approach to moving upstream, and that is mapping out early wins. So the next slide actually describes the process, an example of how one could go about identifying the early wins, the places where you're going to achieve early victories to be able to improve care for patients like Mrs. M. This is where it just is a matter of choosing. Sitting down with your stakeholders in your hospital as a physician leader, and then also bringing in to the table folks who have expertise with the social determinant of health, like the food insecurity. Those examples of organizations with expertise in this space might include food banks, local organizations that provide medically tailored meals, and so on. By bringing them to the table, you can start to identify early wins together. And in this example, the stakeholders decided that they would seek early wins over the next 12 months in these three categories. They would look at ways to reduce hospital use among high utilizer diabetics, such as Mrs. M, using food and associated income support. They also decided that based on the work that's already happening in the community, some existing solutions, that they could try to do a better job at providing vouchers to local farmers markets, or hire a financial counselor so that we could help low-income diabetic patients avoid food insecurity in the first place. And then lastly, they decided an early win they could work on together is to advocate for increases in supports for low-income families in their community, particularly those at risk for diabetes. And you might be asking yourself an important question, which is like, this seems a lot. This seems like a lot that is especially outside of the traditional role of a physician. And this is where the important element comes in of being able to choose early wins, because it's not just about identifying what successes you might have, but more importantly, to clarify what roles the clinical partners, the physician leaders in your hospital specifically, and what will have and what roles the community organization will have. Where will you lead? Where can you partner? And where can you support as clinician leaders? And more importantly, where can the community-based organization lead, and where can they partner, and where can they support? When we clarify roles as part of these emerging partnerships between hospitals and communities, we understand that there is more and more opportunity for physician leaders and other health professionals in hospitals to be able to lead where they are strongest, especially here in the bottom left of the strategy compass, and support where others can lead, for example, on the top right. And this is a way in which now clinical and community partners can come together to be able to, quote unquote, move upstream to identify early wins. So the next slide really is a way to now ask ourselves this most important question. If we go through this process, this stepwise approach of taking a population, a social determinant of health, using the strategy compass to map out existing barriers and opportunities, and then choose some early wins together with hospital and community partners collectively deciding on what the early wins can be and what their roles will be in that process, the question then, of course, is how do you achieve those early wins? And it's in that context that I want to turn the baton back over to my colleague, Sara Bader, who will describe how we can actually translate these early wins into action.
Great, thanks so much, Rishi. So now that you've selected your early win interventions, our roadmap for implementing those is a simple threefold approach to get ready, get set, and go upstream. And I'll spend a little bit of time now going through each one of these in detail. So the first step is to get ready, and in doing so, to assess your organizational capability to go upstream in order to figure out how to best be successful in achieving your early wins. And there are a number of tools out there that can assess organizational readiness, of which one is the HealthBegins Upstream Capability Assessment. And this tool has been developed and iterated on over a number of years and incorporates not only the evolving evidence base, but also the input of healthcare professionals who have used the tool to determine what competencies are integral to moving upstream. So organizational upstream capability is measured across 10 domains, which you can see here. Everything from the external environment. So do you have identified community partners at the ready? What is the value of this work within your organization? Do you have executive sponsorship on board? Are staff and team roles clearly defined? And then also, what are your project management or quality improvement capabilities like? How financially ready is your organization? And as you look at these on the screen here, think about where you perceive your organization to be at. And what you'll see emerge is your areas of strength and your areas of opportunity. And we really encourage multiple people of varying roles and responsibilities within the institution to complete this and to engage in a conversation about the results. Why did one person score something one way and someone else something different? Are different departments or roles generally more ready than others? By going through this exercise and getting an understanding of your organization's capability to do this work, you can better assess and plan for your early win intervention implementation. And that planning happens in step 2, get set. And you can think of this as your planning stage. Now that you know where you are in terms of your organizational capability, you can begin to think about what you need to have in place in order to launch your upstream QI campaign. For example, to start to think about identifying actionable measures and data to track your progress, to refine and implement your workflows and engage and support upstream as champions within your organization and community-based partners to advance the work. So let's look at an example, thinking again about Mrs. M and the hospital who cared for her. So this team has decided to launch their Upstream QI campaign focused on designing a food pharmacy program to reduce hospital admissions for diabetic patients with food insecurity. And they've decided to set a 30-30 goal. Improve screening by 30%, improve provider confidence by 30%, and reduce admissions by 30%. And one way in which they can start to operationalize this is to look at how to optimize and refine existing workflows to incorporate the addressing of social needs. Here, for example, you'll see a standard workflow that charts out the course of a typical provider visit, everything from what happens pre-visit to the screen, exam, refer, and so on. And what this tool, which we call the Upstream Medicine Workflow Canvas, allows you to do is to map out your existing workflows and then identify those areas within that workflow where you can incorporate addressing of social needs. So maybe you'll add in screening for social needs as part of a vital check or an intake process, for example. And then also to get really specific around how are you going to do that. So who is going to take ownership or responsibility for this step, and what will their specific role or process to follow be? What tools are available to them? How will you measure whether or not this workflow is successful? So, and what this leads us to is a really nice way to start to think about using quality improvement to test the ideas that we've come up with in our campaign design get set step. Take what you know about your organizational capability, what you're hearing from your champions, your staff, and your patients, and launch your campaign to achieve your early wins. And using upstream quality improvement methods and tools as a way to test and refine your processes, workflows, and to redesign your systems. And what you'll see as you go through this process is that a transformation takes place. That moving upstream is not only now something you'd like to do, but something that you can do, and that you'll see improved outcomes as a result. So that is upstream QI in a nutshell. To start, you start with identifying your priority populations and priority social determinants. Move on to mapping what you already have in place using the upstream strategy compass and levels of prevention. Identifying an intervention, identifying early wins, and then designing and launching upstream QI campaigns using the Get Ready, Get Set, Go Upstream framework. And so with that, Rishi, I'm wondering if you can take a few minutes before we close here to reflect on the essential role of the physician in doing this work.
Thanks, Sarah. Absolutely. We at HealthBegins think that the role of physicians in moving upstream is essential. As you've heard through the presentation so far on upstream quality improvement, there are many different opportunities in which upstream quality improvement allows physicians to consider the toolkit of quality improvement, the challenge of understanding, if not trying to address, social determinants of health, and merge them together in a way that create new opportunities for taking action. Taking actions not only as individual physicians, but as leaders of care teams and as leaders in our hospitals, especially as partners in the community as well. We know that the truth is that we're trying to all aim for improved whole person care. There are a lot of payment initiatives that are creating new models of payment to improve whole person care by being able to address not just biological, but increasingly behavioral, as well as social determinants of care. We also know that there is a lot of efforts to be able to improve whole person care because of the emphasis on the quadruple aim, to be able to improve experience, outcomes, decrease costs, and of course, advance joy at work. All these initiatives, right, from our perspective at HealthBegins, really rely upon us to be able to do a number of things. But we do know one thing for sure. We can't truly create a whole person care model unless we incorporate health-related social needs into our care systems and do so in partnership with community. We can't truly achieve whole person care unless we work with community partners to address social determinants of health. And we can't incorporate health-related social needs into our systems of care unless we support physicians and other health professionals to do that. This is not something that is automatic. Our systems have not been designed from the get-go to be able to support this type of work. So we can expect health professionals and physicians to do this without supporting them through the process of change, of system transformation. And we certainly can't support health professionals and physicians specifically unless we understand the impact of, that social determinants of health have on 3 C's: care models, capacity, and culture. When it comes to care models, we know that new models of care are required when we start thinking about ways to be able to better screen for issues like food insecurity, or for that matter, housing insecurity, or transportation. Each of these things requires us to look at care models differently, new ways of asking questions at new points in the patient workflow through our hospitals, new opportunities and new models that are required sometimes to think about how we can set up new referrals for patients when we do identify if they have these unmet social needs. We know, in other words, that care models have to change if we're going to be able to do this work, and that the upstream quality improvement can certainly be a method, as you've heard, to be able to improve the models of care. We also know that upstream quality improvement is a particularly useful tool to be able to address the second C, which is capacity. This is not just about turning on the switch for a new model of care or a new software system, although more and more of these tools are becoming available. We know that this is also about being able to improve the capacity of existing teams to work in new ways, and also of new team members to be able to join so that we can collectively start understanding how to implement upstream quality improvement to improve whole person care. What I mean is the capacity of an existing team to address social determinants can only be realized if we use continuous improvement methodologies to figure out how to refine our models of care, and also how we refine new ways of working together. Increasingly, what we're finding is that requires us to also invite new team members into to the fold. More and more hospitals are looking at ways to engage community health workers, at being able to build bridges with existing, if not new, social workers, and even build bridges with folks that we never thought would be part of a quote-unquote care team. For example, medical legal partnerships are an increasing model of care in many parts of the country right now, in which hospital-based clinicians are now working with public interest lawyers to be able to address unmet social and legal needs, especially of high-need, high-cost patients. So we're looking at new team members joining existing teams, and at existing teams finding new ways to increase their capacity. Again, quality improvement and upstream quality improvement is a mechanism to improve the capacity of a team to take on new challenges and new tasks. And lastly, we know that through upstream quality improvement and through this work in general of moving upstream, that this has an impact on our culture. We know this changes our norms and expectations of who we are as health professionals, and the norms and expectations of a community, including our own patients, of what they can come to expect of us. This is an important element that sometimes doesn't go spoken, that we don't speak to a lot, but it's a really important element to consider as we're moving upstream, to think about the impact it has on our own cultural expectations of who we are as professionals and as partners in the community. So moving upstream is essential, and the role of physicians moving upstream is absolutely essential. We'll end today's presentation by asking you to really consider a couple of key things now that you've heard about upstream quality improvement as an overview. We ask you to think first about the use of quality improvement itself to advance your own upstream projects. Have you been thinking about projects that you currently have or that you're thinking about implementing to address issues like food insecurity or housing insecurity or transportation? And if so, can quality improvement be a methodology that can be useful for you? Do you have any partners in terms of QI staff? Are there methodologies and tools that are available to you in your hospital in terms of quality improvement that can be useful for your project? And if so, what barriers exist to being able to tap into those assets so that you can move upstream? And as importantly, what are your opportunities? Who are your partners potentially to be able to collaborate when it comes to implementing a quality improvement project to address an issue like food or housing insecurity or transportation? We invite you to think about these opportunities as well as these barriers. And as you do so, stay tuned for the upcoming modules that we have in this series. We're going to be focusing in a deeper way on how upstream quality improvement can help address food insecurity, housing insecurity, and transportation. And our hope is that each one of these modules, as part of this overall AHA conversation on social determinants of health, can be a helpful resource as you, as a physician leader in your own care team, in your own hospital, and in your community, learn how to address social determinants and achieve that quadruple aim. We thank you for spending your time with us today. Sarah, thank you so much for presenting along with me today, and looking forward to talking to each of you in the near future through the rest of this conversation on social determinants of health. Thank you.